Pleasure to be speaking to you today. I want to thank the organizing committee, Dr. Nitesh, for the kind invitation. Thank you, Dr. Rangarao and Dr. Shyam Agarwal for this opportunity. A lot is happening in 2020 and we can't wait for 2020 to be over. But one of the things as a sports fan, I will remember about 2020 is when MS Dhoni decided to step down as cricket fan. What great memories he shared with us and what a great leader he has been. And I know Dr. Sanjay Papat, who follows closely after me in this session, will also share my thoughts and appreciation for MS. Couldn't not start without that acknowledgement. These are my disclosures. When we talk about EGFR mutated non-small cell lung cancer, there's no question that we've come a long ways in the past 15 years. 2004 was the year the EGFR mutations were described. And since that time, there has been tremendous progress. And I can't fit all in one slide because at 2018, I had to stop, considering that there have been even more developments in the upcoming, in the last 2 years as well. What I'm going to focus on for this talk is exon 19 and 21 mutations. These are the mutations that account for nearly 85% of all EGFR mutated non-small cell lung cancers. And I would start off by saying that any patient diagnosed with stage 4 non-squamous non-small cell lung cancer, this day and age should have NGS testing to make sure we look for molecular aberrations that can be treated with targeted therapies. Now, there are some uncommon EGFR mutations that perhaps we can talk about in the panel discussion, and I won't get into that too much. When we talk about the various generations of EGFR TKIs, now we have 3 generations, and there are distinct differences from one drug to the other or one group of agents to the other. The 3rd generation drug, osimertinib, and there are a few others in development, are characterized by the fact that they are more specific to the mutant receptor. There's almost a 300-fold higher selectivity to the mutant receptor compared to the wild type receptor. And this allows for a better safety profile. We also know that the 3rd generation drug has more CNS penetration, and I'll touch on that as we get further along. Now, in the past 15 years or so, we've had a number of randomized clinical trials that have all showed us that first-line EGFR TKI therapy is superior to chemotherapy in EGFR mutated patients. You can see the trials for gefitinib on the slide, the trials for erlotinib, 2nd generation drugs, afatinib and dacomitinib. And the median progression-free survival is fairly well described for all of these drugs. With gefitinib, we'll talk about 9 to 10 months. With erlotinib, very similar to gefitinib. Afatinib and dacomitinib, perhaps a little higher, 11 to 13 months. With dacomitinib, the Archer study showed a median PFS of 14.7 months, but remember that study excluded brain metastases. So this is a slightly more favorable prognosis. I viewed afatinib and dacomitinib as very similar drugs. So we know these are the benchmarks. This is what we have come to expect from 1st and 2nd generation agents. In the US, the NCCN guidelines now flag osimertinib as the preferred frontline therapy. I mean, you can use any one of these agents, but osimertinib has the preferred status. Why is that? Well, you're familiar with the FLORA study. This has been published in the New England Journal. This was a randomized comparison of osimertinib versus either gefitinib or erlotinib. This study included 556 patients. Primary endpoint was PFS, and overall survival was a secondary endpoint. We allowed crossover in the study for patients in the control group, those who received gefitinib or erlotinib, if they developed disease progression and if they had the T790M mutation, they were allowed to receive osimertinib as second-line therapy. We had 2/3 of the patients with exon 19 mutation and 1/3 with exon L858R, and 2/3 of the patient for this study came from Asia. Here are the progression-free survival results. We're very excited to see that the median PFS was close to 19 months. The control group did just as well as what one would expect with 10.2 months. And we also saw that there was comparable hazard ratio between patients with brain mets at baseline versus patients without brain mets at baseline. And the hazard ratio of 0.46 was highly statistically significant. So these results led to the approval of osimertinib in many parts of the world for frontline therapy of non-small cell lung cancer. More recently, we were able to also show that there was improvement in overall survival. This is in fact the first time in EGFR mutated lung cancer that a TKI therapy has shown improvement in overall survival over a comparator. The median survival was improved by about 7 months. And in fact, the median survival was well over 3 years for patients with exon 19 or 21 mutation. The side effect profile of osimertinib was also quite favorable. There was lower incidence of skin rash, lower incidence of liver toxicities, and overall lower incidence of treatment discontinuations related to grade 3 or 4 toxicity events. A key problem we face in the management of patients with EGFR mutation is brain metastasis. Almost 45% of patients with EGFR mutated lung cancer will develop brain mets sometime during the course of their journey, unfortunately. About 20% will have brain metastases at the time of diagnosis. So it is incredibly important that the agent we choose for managing EGFR mutated patients has CNS activity. We also know that leptomeningeal disease can happen at some point, particularly during the latter part of the journey for a patient with EGFR mutation, and certainly other types of non-small cell lung cancer as well. So we looked at FLAURA results based on brain metastases. This is exactly what I mentioned to you a minute ago, where patients with CNS metastases, there were about 20% of the patients in the study that came in with brain mets at baseline. And you can see that the median PFS was superior for osimertinib versus standard of care in both arms, and the hazard ratio was identical. More importantly, patients treated with osimertinib were almost 2.5 times less likely to develop progression in the brain compared to the standard of care arm. This slide shows additional information that supports CNS activity of osimertinib. We show results from the FLAURA study on one side and the AURA3 study, which compared osimertinib to chemo in T790 positive patients in the second-line setting on the other side. This is specifically calling out patients who had brain metastases at the time of study entry. And you see that the intracranial response rate is 90% in the FLAURA study and 70% in the AURA3 trial. And the median duration of response in the brain and the median PFS in the brain are quite remarkable for both of these studies for patients treated with osimertinib. This further proves that osimertinib is effective against brain metastases. Now, there are cost benefits and quality of life benefits when you can control brain metastases. Every time you have to do SRS to the brain or gamma knife to the brain, it's associated with the cost and substantial symptoms and quality of life impacts on patients. So having CNS activity has substantial clinical patient benefits. We've also seen from Dr. James Yang's study done in Asia that osimertinib has effectivity against leptomeningeal disease. This is a study with 41 patients. They received osimertinib 160 milligram per day. We don't think we need 160. At 80 milligrams per day, you get sufficient brain penetration. The response rate here is 62%. Median survival is almost a year. And more importantly, neurocognitive assessment studies showed that patients were able to recover neurocognitive functions when treated with osimertinib in this trial. So osimertinib is now used routinely as frontline therapy. In fact, in the US, this is the go-to drug in the frontline setting, and so is the case in many parts of the world. The questions about combinations therapies is very germane because we've seen some exciting results in this setting. Let me talk about the RELAY trial. This was a randomized comparison of erlotinib with ramucirumab. Now, ramucirumab, as you know, is a monoclonal antibody against VEGF-R2 receptor. The comparator group was erlotinib and placebo. This study excluded patients with brain metastases, and they showed that the median PFS was about 19 months. There was superiority. In fact, this combination regimen was approved by the US FDA about 5 months ago. We don't have the survival results from this trial, These results are similar to what we've seen with other trials of gefitinib or erlotinib with bevacizumab. None of these trials to date have showed improvement in overall survival. There was a recent analysis at ESMO 2020 from this trial that showed that perhaps patients who have p53 co-mutations with an EGFR activating mutation may benefit from the combination. At this point, I do not recommend this combination for standard of care. It has an approval in European Union, not in the United States, for the erlotinib or gefitinib combinations. And there is obviously interest in studying osimertinib plus bevacizumab. This is a single-arm study conducted by Memorial Sloan Kettering. And in this study of about 50 patients, they showed that the median PFS was about 19 months. They showed high clearance rate of ctDNA early on in the form of therapy. And there is a trial that we're conducting through the Eastern Cooperative Oncology Group that compares osimertinib alone to osimertinib plus bevacizumab. So the final word is yet to be said on this. This has additional toxicity implications when you combine an anti-angiogenic agent with the TKI in the form of bleeding, proteinuria, hypertension, and so forth. So it also has the barrier of having to give this drug intravenously for sustained lengths of time. So at this point, what I would say about this combination is it may be appropriate if we see survival results show a positive in patients treated with combination regimen. An area where there's really a lot of excitement is the EGFR TKI plus chemotherapy combination. You're very well familiar with the study from Tata Memorial by Dr. Noronha. This is published now, where she and her group showed that combining gefitinib with chemotherapy was associated with improvement in progression-free survival and overall survival compared to gefitinib alone. These results were very similar to another Japanese trial that has also showed these results. So if you choose gefitinib as a frontline regimen for your patient, I think it's reasonable to add chemotherapy on top of it. There is also an ongoing trial referred to as the FLORA-2 study that combines chemotherapy with osimertinib. In my view, as we understand who are the patients who are less likely to have durable benefits with osimertinib, identifying those patients with persistence of disease even early on in the course of treatment, adding chemotherapy at that point may be beneficial as opposed to giving everybody chemotherapy. That's where I see the future heading, not everybody getting chemo plus TKI, but starting with TKI early on in the course of treatment using peripheral blood to look at who has persistence of ctDNA and adding chemo or other aggressive approaches at that point. Now, we're not there yet. At this point, if you choose osimertinib as frontline therapy, I would give it as monotherapy. If you use gefitinib, I believe it's reasonable to add chemotherapy in that situation. Where do we stand with immunotherapy in EGFR mutated patients? I think there are a couple of important points. We've seen now in multiple studies and in this meta-analysis that for patients with EGFR activating mutation, TKIs, immune checkpoint inhibitors don't do very well for EGFR mutated patients. The response rates are very low for patients treated with checkpoint inhibition in the EGFR mutated setting, and their PFS results are also very low. Here are randomized trials that compared docetaxel to immune checkpoint inhibition, and these trials showed superior survival for immune checkpoint inhibition. However, the top half of the slide shows you that for wild-type patients, PD-1 inhibition was better than docetaxel. In the lower half, when you look at the EGFR mutated patients in these studies, the hazard ratio actually favors docetaxel compared to PD-1 inhibition. So I don't use PD-1 inhibition as monotherapy for patients with EGFR mutated disease. What about chemotherapy plus IO after patients receive TKI and have developed acquired resistance? Again, there is no prospective phase 3 trial in the study that has shown this regimen combination to be beneficial. The Empower 150 study, which looked at chemo plus bevacizumab plus atezolizumab, did a post hoc analysis, and they suggested that for EGFR mutated patients, the 4-drug combination had demonstrated favorable PFS after they have progressed on EGFR TKI. I don't think this is ready for prime time. I would do there are prospective trials ongoing, in fact, and I would wait for those results before we use this for routine patient care. Another key point to keep in mind is if you give a patient an immunotherapy and then switch them to TKI, there are some additional toxicities. This is a small series of patients from Memorial Sloan Kettering, where they looked at patients who received immunotherapy and they had to switch to TKI. And in fact, patients who switched from immunotherapy to osimertinib, 6 out of 41 patients developed serious toxicities. Remember that the PD-1 inhibitors have long half-life. They stick around in the system for 2 to 3 months. So this is yet another reason why when you don't have the molecular results, don't start immunotherapy, wait for the molecular results to come back, and then start whatever appropriate therapy is based on what you find. If you have to start some therapy in a patient as first-line treatment, start with chemotherapy alone. When you get the molecular results, if you have mutation, you can switch safely to a TKI. If there's no mutation, you can add immunotherapy if that is your preference. What about adding radiotherapy and EGFR TKI inhibition? There was a study reported at ASCO where they randomized patients with EGFR mutated disease. This was a study conducted in China, where they gave TKI to the control group. And for the experimental arm, they gave SBRT to patients who had metastatic lesions. They treated up to 5 lesions. And they treated every one of these lesions with the objective of eradicating macroscopic disease and see if that results in better outcomes. Well, they showed improvement in PFS and survival for the group that received SBRT and TKI. However, even the control group in this study underperformed. The median survival group for the experimental arm was only 19 months. Now, considering that for EGFR mutated patients treated in Asia, the median survival is somewhere in the order of 40 to 50 months. To me, these results don't strike home as representative of truly what we see in the real world setting, and I would not jump to give SRS to every patient. However, if you have a patient on a TKI therapy, and with the course of time, the patient develops oligoprogression in 1 or 2 sites, it's very reasonable to give stereotactic radiosurgery and continue the patient on TKI. Finally, we're beginning to learn about resistance mechanisms to osimertinib. These are plasma data. These are results we presented at ESMO in 2018. You can see that secondary EGFR mutations in the form of C797S mutations happen in somewhere 7 to 10% of the patients. Meta amplifications happen in approximately 15% of the patients. And for these patients, combination approaches that build on osimertinib could be studied. And in fact, some early results with the combination of osimertinib and savolitinib, which is a MET inhibitor, has shown promise, and there's an ongoing study in this setting. For now, when a patient progresses on osimertinib, platinum-based chemotherapy remains the standard, but hopefully down the road, with some promising agents that are coming up, we might be able to reverse resistance. I would also reference a study that was just reported at ESMO 2 weeks ago, where this drug called U3-1402, which is an antibody drug conjugate against HER3, in this particular acquired resistance setting, has shown response rates of about 25%, and a very interesting waterfall plot with benefit in more than 50 to 60% of the patients. That's a small phase 1, phase 2 study. We have to see how those results hold up. We don't have median PFS results from the trial, but certainly there are some interesting approaches that are being developed down the road to keep our eyes out for. Now, what about if you started a patient on erlotinib, gefitinib, or afatinib in the frontline setting, acquired resistance happens, we should check those patients for T790M mutation. You can check it in plasma or in tissue, and regardless of where you find it, osimertinib therapy is effective. These are AURA3 trials. Dr. Mark reported this in the New England Journal. He's going to be a speaker in the next half an hour or so. He showed us that when compared to chemotherapy, osimertinib was superior to platinum-based chemotherapy. The median PFS was 10 to 4.4 months. So for second-line therapy, if a patient has not received osimertinib in the frontline setting, making sure we check for EGFR T790M mutation is critical. So there's a lot of exciting developments in this field. Obviously, I wanted to keep this talk clinically relevant for our patients, and I'll be happy to take questions. We can conclude by saying that osimertinib has emerged as the best in class for EGFR mutated non-small cell lung cancer, based on impact on overall survival, based on its ability to act against brain metastases, and a favorable safety profile. Combination approaches both to delay and to overcome resistance are next going to be the focus of our ongoing studies. And acquired resistance continues to be a challenge, even with exciting new therapies. And hopefully, these promising developments that we see on the horizon will come in soon and fill the space. Let me stop there and thank you for your